Welcome back to part 2 of chapter 9 lecture video on joints. So in part 1, we have ended by talking about and introducing synovial joints with their general structures and accessory structures, along with all the articular motion that they enable us to do. So now we're ready to break down the synovial joints into the 6 specific subtypes of joints. The first of those are called the plane joints, which are usually flat or just slightly curved that slide across each other at the articulating surfaces. So obviously they can only conduct the gliding movement. So if this is one articulating surface that's flat and this green portion here is the other articulating flat surface, and you're gliding either front and backwards, left and right, or to the side diagonally like that. So that's why it's considered as a non-axial movement. It can only do gliding. Example of plane joints are, for example, your claviculosternal joint, which is a joint between your clavicle bone and your sternum, specifically the superior part of the sternum called the manubrium. And there's this flat surface of the clavicle and the flat surface of the sternum that forms that joint. The intercarpal joints between carpal bones are also another example of the plane joint. If you remember that the carpal bones are box-shaped bones with flat surfaces and they glide across each other. So you have your carpal bones that shapes like little boxes like this, and then you have your metacarpals and then the phalanges, etc. So these are the intercarpal bones we're talking about when we're talking about the example of the plane joint. And lastly, you have the example of vertebrocostal joints, which are between the ribs and the vertebral bones. Again, we're talking about the flat surfaces, flat surface of the rib and flat surface of the vertebral bone. The vertebral bones are kind of looks like this with the vertebral body and the spinous process. And then you have your ribs coming anteriorly like that. So that joint right there where the ribs connects to the vertebral bone is that vertebrocostal joint we're talking about, that enables our ribs to kind of lift upwards and outwards whenever we take a deep breath. Okay, we need that slight movement, that movement of your rib cage that enables the thoracic cavity to be bigger and allow air to flow inwards. We'll talk about that BIOL's law when we get to the respiratory system lecture in the next semester. And I'll show you an animation of this with an app of that thoracic cage movement. Okay, so the second second subtype of synovial joint is called the hinge joint, which are those that work just like a hinge on the door. So when you're in doubt of whether a joint is a hinge joint or not, just think about how a door opens and closes. It provides that angular motion along one axis of movement, so that's why it's considered as monoaxial. An example of hinge joints are your elbows, knees, and ankle joints. All of those only allows that free motion along one axis. If you try to move it along another axis, you can't. Just like how you can swing a door open and close, but you can't swing it upwards or downwards. So here is illustrating that. Here's a hinge joint moving upwards or downwards, but if you try to twist it this way or that way, you're going to break your arm. And for example, in the elbow. So it only allows you to do flexion and extension at the elbow. Here's the humerus bone of your upper arm, and then your forearm is right here formed by the ulnar bone. And the olecranon of the ulna here fits into the olecranon fossa on the humerus to form that hinge shape of a door. Okay. All right, and the third subtype of synovial joint is called the condylar joints, which are those with the oval articulating surface. One bone would be convex and the other would be concave for the convex bone to nestle within it and move against it. So here's that convex part of the bone and here's that concave of the bone. And that's why, because of those curvatures, they're not restricted by a hinge or anything. That's why they can move in biaxial directions, moving forward, backward, or sideways. So that's why it's considered able to do biaxial movement along two axes. An example of condylar joint is the radiocarpal joint, which is that between the radius bone, the distal end of the radius, and the carpal bones of the wrist. It allows for flexion, extension, abduction, adduction of the wrist. The second and third example is similar. They're the metacarpal phalangeal joint, that are those in your fingers where your knuckles are. So it's what allows you to move your fingers. When you imagine your four fingers moving toward the front or the back, kind of like a tapping motion if you tap your desk, or a side to side motion like a no motion with your four fingers. The metatarsal phalangeal joint are then those in your toes. So that's why we went over those surface anatomy in lab 1 to get you familiarized with those terminology that gives you a good idea that general location of bones or muscles, in this case bones and joints. So carpal here tells you that it is your wrist, and tarsal here tells you that it's something dealing with your ankles and hence your toes, and you won't mix fingers and toes together. All right, so the fourth subtype of synovial joint is called the saddle joint, which are those with complex articular surfaces that fit together like a rider here and a saddle because of the way they are shaped. They're shaped in that special manner that they fit together nicely. And a good example of that is your first carpal metacarpal joint, which is that in your thumb. So this is the metacarpal of your thumb. This is the carpal called trapezium carpal bone that articulates with the metacarpal bone of your thumb. And it is this joint right here that allows it to move this way or to the side. So saddle joint is also a biaxial joint that allows for flexion, extension, abduction and adduction, and even a little bit circumduction of the thumb. The fifth subtype of synovial joints are those that only permit rotation. So it only allows you to rotate like carousel, horse carousel in the carnival. Okay, you can turn this way or that way, but you can't try to pull it up or down. Okay, so it only permit rotation. A good example of that is the atlantoaxial joint that allows for our medial and lateral rotation to turn our head left and right. This is your atlas and this is your axis, and atlas fits into axis with the dens right here and allows for the twisting of your head this way or this way by these bones rotating against each other. The other example of a pivot joint is the proximal radial ulnar joint, which is right at the elbow. It allows for your supination and pronation articular motion. The radius actually rotates next to the ulnar as you are doing that motion of supination and pronation. So that is why when you're looking at the head of the radius, it actually kind of looks like a round shape for that rotation. So if you look into the radius, it has that circular head, and then the rest of the diaphysis of the radius bone. But this definitely has that circular shape for that twisting motion, rotating this way or that way for that rotation movement, supination, pronation. The sixth subtype of synovial joint is called the ball and socket. And the name speaks for itself how it should look like. There's the round part of the ball, okay, which are bones with a head that are more in that spherical shape, and it fits perfectly into that cup-shaped depression on the other bone. Because of the shape of the articulating surfaces, this is why ball and socket joints can move along 3 axes, known as triaxial joint. It can complete angular, rotation, and even circumduction movements. Example of this joint is the shoulder and hip joint. The shoulder joint is where the head of the humerus right here fits perfectly into the glenoid fossa of the scapula bone. And the hip joint is where the head of the femur, which is pretty obvious on the femur, okay, that fits into the acetabulum of the oxcoxa bone, where it has that big, nice spherical indentation for the head of the femur to fit into it, for that ball and socket joint. So this is a quick video that goes over these synovial joints and gives you that animation feel of these 6 joints, and go through a little bit of explanation just as I did. Okay, so you get a little bit view of the 2D dimensional picture and an animation style.
Arthroses are freely moving joints or articulations. There are 6 types of synovial joints. They are characterized by the presence of a cavity enclosed by a capsule. The geometric structure of these joints permits certain types of movements. A ball and socket joint, multi-axial, provides the widest range of motion. Movement can occur in all planes and directions. The hinge joint, uniaxial, limits movement to flexion and extension. Here, a convex surface fits into a concave surface. Examples are the knee, elbow, and the middle and distal phalanges of the fingers and toes. The pivot joint, uniaxial, limits movement to rotation in one plane, such as the atlas and axis articulation in the spine. The condyloid joint, or ellipsoidal, biaxial joint, allows motion in 2 planes at right angles to each other, as in the wrist joint between the radius and carpal bones. The saddle joint, biaxial, found only in the thumb, allows movement in 2 planes at right angles to one another, located at the carpal metacarpal articulation in the thumb. The gliding joint, multiaxial, the last type of synovial joint, allows only gliding motion, as in the intervertebral joints in the spine. An articulation is a place of union or junction between 2 or more bones. The functions of synovial joints are to bear weight, allow movement, provide stability, lubricate the joint, and nourish the cartilage.
Okay. All right, so let me make sure it's still recording. Okay. So now we're going into the detailed structures of specific joints. Your textbook and lab manual actually goes into a number of joints, but we're going into details of just 2 joints because you already have enough information to remember already. So the 2 that we're going to go into are the intervertebral joint and the knee joint. Now, the intervertebral joints are those that are formed between adjacent vertebral bodies, just like your symphysis joint we talked about from the part 1 of the lecture, or joints between adjacent articulating processes, which are considered as synovial joints. Now, from the axis and all the way down to the sacrum, there is no intervertebral disc. There are intervertebral discs, pads of them between the vertebrate bones from the axis to the sacrum. Okay, so that's what these things are between your vertebral bones. Now, what I was about to say is that there is no intervertebral disc between the atlas and the axis, which is between the atlantoaxial joint, because on the atlas vertebral bone, there isn't a vertebral body for there to be an intervertebral disc. So that's why you don't have an intervertebral disc underneath the atlas. Okay, so the tough outer layer of the intervertebral disc is made up of fibrocartilage. You have, your intervertebral disc is divided into 3 parts. You have the outer side, the center, and then you have the superior surface and inferior surface. If we draw it transversely speaking, you have a circle that represents your intervertebral disc, and then you have the center of it. Okay. So the outer part here is known and called as the annulus fibrosus, which attaches the disc to the bodies of the adjacent vertebrae, mostly because they're the outer part, this part of the intervertebral disc. The second part of the intervertebral disc is called the nucleus pulposus, which is the center area right here, or this yellow area within the intervertebral disc, and is made up of soft, elastic, gelatinous core that it helps to absorb shock. Remember, we talked about that intervertebral disc has the ability to resist compression by these heavy part of our body that are maintained by our vertebral column. And the last part of the intervertebral disc, you have what's called the vertebral end plate, which is that superior layer and inferior layer. They cover those surfaces of the vertebral body, either your upper bone or your lower bone. And they're mainly made up of hyaline cartilage and fibrocartilage, a combination of the two. Now, all of these parts of the intervertebral disc is what allows that smooth gliding movement, as you've seen in the video earlier, and maintain alignment of your vertebral column. Now, as we age, not only do we have to experience osteoporosis, but sometimes we tend to seem to lose our height as well, not because we just magically became shorter as we age, but because of these intervertebral discs, the nucleus pulposus area can decrease in size. The content inside loses, its mass, okay, and you have water loss as well. And that's what together, all the intervertebral discs being smaller and more compressed, that's what results in that reduction in height as we age. Okay, and then you have, we talked about the importance of ligaments for binding those joints together, and there are usually more than one ligament that connect bones in a joint. Just for the intervertebral joints, there are 5 different ligaments that work together to stabilize those joints that form our back. You have first your ligament flava, which is this one right here that connects the laminae of adjacent vertebrae. If we're looking at the anterior side of the vertebral column, that's the ligament flava. And if we're looking at the lateral side of the vertebral column, this is the ligament flava that can happen between every adjacent vertebrae bones. Posterior longitudinal ligament, the name kind of speaks for itself. So posterior means the back, longitudinal means going downwards longitudinally. So this one right here is where the posterior longitudinal ligament exists, and sideways we're talking about this line right here going down the entire vertebral column, and they connect, of course, this posterior portion of the vertebral bodies that are next to each other. Okay, and then the interspinous ligament, again, the name speaks for itself. Remember, this is called the spinous process of the vertebral bone. So interspinous, between the spinous process of the vertebrate bones. So this area here, those are called your interspinous ligaments that connect the spinous processes of the adjacent vertebrae together. Supraspinous, again, the name tells you what it does. Supra being on top of, okay? So this here that lays on top of this the spinous process is the supraspinous ligament, okay? So this is the longitudinal going downwards, that attach the tips of the spinous process from your C7, which is the 7th cervical vertebrae, all the way down to the sacrum. Now, what happens above your C7? So what happens above your C7 towards your skull there is something else that binds these together called ligamentum nuchae. I'll show you how these looks like on my app at the end of the chapter. But if you have the head like this, and then the neck, okay, and then the shoulder, the arms. So this part, you have that nice supraspinous ligament. And then what happens from here, the seventh cervical vertebrae, all the way to the back of the skull, is this fin-looking thing. I think it really looks like a fish fin or something. But that's how the ligamentum nuchae looks like, connecting your cervical vertebrae to the back of the skull. And the last part, ligament of the intervertebral joint, is your anterior longitudinal ligament, which is kind of analogous to your posterior longitudinal ligament, except that is in the front. So this part is the anterior longitudinal ligament. This here is also the anterior longitudinal ligament. And they connect, of course, the anterior part of the vertebral bodies next to each other. Okay, so all 5 of these ligaments is what allows safe and stable movement of our vertebral column, such as flexion, extension of our back, lateral flexion, and even rotation of our back. Okay, so these 5 ligaments enables that when we're doing those movements, our vertebral bones won't move out of position. Now, there are 2 common problems that can happen with intervertebral joints. We talked about how things are supposed to stay in place, but sometimes if those ligaments are not functioning as they should, we can have sort of dislocation of these vertebral bones. For example, bulging disc is a condition where the posterior longitudinal ligament that's supposed to bind this, make sure this stays in line together, that ligament can be weakened. And now, because of that weakening problem, the intervertebral disc can push this way into the ligament, and it can result in distortion of the shape of the annulus fibrosis. If you remember what I just talked about with the transverse cut of your intervertebral disc, this outer region is the annulus fibrosis, and that become distorted in shape because of being compressed due to the weakness of that ligament. It doesn't hold it together and force it part way into the vertebral canal. Now, what's a more serious problem is when you have a herniated disc. This is when the nucleus pulposus, which is that center part of the intervertebral disc, also starts breaking through into the annulus fibrosis area and protrude into the vertebral canal. Now, the vertebral canal is where your spinal cord goes through. We'll go over that in chapter 13 when we talk about spinal cord and nerves. But because now you have this part of the intervertebral disc compressing into that area, you can compress spinal nerves, and that can cause severe pain because you're smushing these nerves and smashing those nerves that are radiating out from the spinal cord area in every single one of those vertebral bodies. You see what I mean when we get to those chapters. But that's what a herniated disc means. Okay, so now moving on to the second joint we'll discuss in detail, which is the knee joint. It is one of the major joints that transfer the weight of the body from the femur to the tibia and function as a hinge joint, as we have talked about. Now, there are 3 separate articulations for the knee joints. Okay, 2 involves articulation between the femur and the tibia bone. So this right here, the lateral condyle and the medial condyle, is the 2 articulation. The third one lies between the patella, which is about right here in this area, and it articulate with the femur bone. Okay, so this is the femur bone, and this is the tibia bone. So 3 different articulating surface that's happening with the knee joint. Now these are actually within the joint capsule and cavity. There are 2 other accessory things, kind of what I was talking about in terms of, other than the articulating cartilage, there's pads of cartilage wedged between the joint, and that's what this meniscus is. You have the medial meniscus and the lateral meniscus. Okay, so two meniscus makes up the cushions, the two joints together. Menisci. Okay, plural is Persian of meniscus is menisci. Okay, so those for the cushions, the two articulating bones of the femur and the tibia. Okay, they will actually conform to the shape of articulating surfaces as the femur changes in position. So that's why if you look at models of these meniscus, you'll see the meniscus actually kind of looks like that conforms to the curvature of the condyle of the femur coming downwards. Okay, it provides that lateral stability to make sure your tibia doesn't move out of position. Okay, all right. So the accessory structures of the knee joint contain a tendon and a number of ligaments. Because this knee joint is something we move all the time, there are quite a bit of ropes and wrappings that goes around this joint to ensure that it doesn't move out of place or fall apart easily, or else we can't walk when our knee joint is not stabilized. So the first of those is called the quadriceps tendon. Remember, tendon connects muscles to bones. So it passes over the anterior surface of the joint and is responsible for extending the knee when this muscle right here contracts, which is this particular muscle, as we will learn in the muscle identification lab, is the rectus femoris. Okay. And you have that quadriceps tendon here that connects to the patella bone, okay? And then you have two other things that stabilize the position of the patella, okay? Because patella really is not connected to any bone. It's just a small little piece of bone that sits in front of your femur, okay? So there needs to be something on top, which is the quadriceps tendon, and there needs to be something that goes on the bottom, okay? So inferior to the patella bone, you have another ligament that stabilizes the position of the kneecap. It's called the patella ligament that goes downwards this way and then attaches to the tibia bone via the tibial tuberosity right here. And that's why we had you identify that particular bone marking on the tibia bone. And remember that when we mentioned the importance of bone markings that protrudes on the bone, it's usually areas where tendons or ligaments attach to. And in this case, you can tell it is for the is for that attachment of the patella ligament to the tibia bone. And then you have a pair of patella reticula, so depending on plural or singular form, they both support the anterior surface of the knee joint even further. And then you have popliteal ligaments, which extends between the femur and the heads of the tibia and fibula. So there's this one right here, it's a popliteal ligament, and this one right here. Both of them are attaching the femur towards your head of the tibia bone and the fibula bone. This reinforces the knee joints at the posterior surface. So popliteal, P-O, pop, for posterior surface, not the anterior surface of the bone. And then you have 4 other ligaments that stabilize this joint. Like I was saying, the knee joint is very critical, so we want to make sure it stabilizes really well. Okay, so you have your what's called the ACL. We always hear about ACL and PCL. Those are ACL is a commonly damaged ligament with athletes and sports, but the long name for that is called anterior cruciate ligament, or PCL, posterior cruciate ligament. And what they do is they attach the intercondylar area of the tibia to the condyles of the femur. So you can actually see those 2 ligaments in these 2 pictures here because it's within the condyle. So if we will want to look at it, is actually in the previous picture here. So this is that anterior cruciate ligament, ACL. This is the PCL, posterior cruciate ligament. See how it crisscross in between the condyles of the femur. And that further stabilizes. And what happens, the main goal of these ACL and PCL is to maintain alignment of the femur with your tibial condyle, so your tibia doesn't move out of place. If the ACL was torn, your tibia will be able to move even more forward, easily discontinuing the joint of your knee. Okay, and then you have two other ones. You have your front and back. Well, what about side to side? There are two ligaments that prevent side to side movement of the knee joint. You have the medial collateral ligament, the MCL, or the lateral collateral ligament, which is the LCL. Medial is also known as the tibial collateral ligament because it actually attaches to the tibia bone. Okay, so if you look at this one here or this picture here, this is the anterior part of the knee. This is the posterior part of the knee. So this one that attaches to the tibia is the tibial collateral ligament, or the MCL. This one that attaches to the fibula is the LCL. That's why LCL is also known as the fibular collateral ligament. Both of them are reinforcing that lateral surface to prevent lateral movement of your tibia bone side to side and make sure your knee is stabilized. So this is a total of 1, 2, you have the 2 on the side, and then you have the one that goes between ACL and PCL, so 3, 4, and then your popliteal ligament, 5, okay, and then you have your patellar ligament, 6, and quadriceps tendon. So but with here, we're already mentioning 7 different tendons and ligaments that connects, make sure your knee is stabilized nicely together. So that's a lot of stuff just to keep that knee in place. Okay, but, even though there's a lot of protection around the knee, they are not foul-proof against excessive forceful impact. They're not chains and metals, So there are some common knee injuries that can occur in sports especially, or in people that have arthritis or mostly arthritis, because we're talking about joints here. Knees are usually most stable when it is straight, meaning that we have the femur completely nicely aligned with your tibia. Okay, along the same axis like that. But when one locks their knees, okay, this is when you lock your knee, you actually move that line of axis away so that your femur no longer aligns straight with your tibia, and makes it a lot easier for someone to accidentally strike you at either the lateral or medial side and move your tibia. And because of that strong movement, you can actually end up tearing along the meniscus within the knee joint, okay, and along with the supporting ligaments that can tear as well. If the lateral surface of the leg is driven medially, then the medial meniscus can tear. And torn cartilage, as we have talked about, they may restrict the movement at the joint because they may change shape. The meniscus itself supposed to, conform to the shape of your femur. But if it's torn and no longer has that nice shape, it can actually prevent that movement that you're supposed to form at the knee. The other thing about cartilage we learned from chapter 4 is that they don't really heal because of absence of blood vessels. So, when you have a meniscus that's torn, it can take more on how to fix it. So when a torn meniscus happens, this can sometimes lead to unstable knees, and that can actually cause something called the trick knee, where you may hear the meniscus pop in and out of position when one extends the knee, because the meniscus is torn and hence the shape doesn't fit as well anymore. Or some people can even, with the trick knee, can cause them to buckle and fall because of that unstable knee. Now, Torn meniscus may or may not require surgery, as I was talking about, depending on the severity of the damage. Some surgeries may even involve replacing the meniscus with one that comes from another cadaver body, for example. ACL injuries are those that what we hear about most often in athletes. This is usually caused by twisting an extended weight-bearing knee, and this can also lead to the trick knee situation we were talking about earlier, because trick knee situation is pretty much means an unstable knee, and that can be caused by multiple reasons, either a torn meniscus or a torn ACL as well. Now, you see, this is an example of how you can end up with ACL injuries. Is, for example, in football, everybody is very strong. Okay, so he is holding the football while bearing weight, trying to run. Okay, so one of his leg is up, and you're bearing weight on that one leg that's right there, and all his weight is bared on this leg, and someone knocks him over with the helmet, with the head, right into the knee. And you know how strong football players are. So that force coming at you, pushing that tibia away from your femur, can actually overbear the tension that your ACL can take and cause your ACL to tear. Okay. Now, torn ligaments are difficult to correct surgically, and healing may happen or may not, but it is definitely slow, especially if you're talking about a completely torn ACL. So usually reconstructive surgery using either a part of the patellar ligament or a graft from a cadaver will be used. I will upload a video to eCampus as a supplemental movie, which is a pretty short clip, 2 minutes or something like that, 2 to 3 minutes. But it's a very cool video that shows you the parts of the knee joint, and also what goes on when it is damaged, and also what happens surgically to fix the damage afterwards. Okay, I will upload that to eCampus, so be sure to watch that. It's very interesting to me how we can come away with those type of ways to heal a knee joint and a torn ACL. All right, so the patella injury is another injury that can happen with the knees. Now, so you can break meniscus, you can tear meniscus, tear ACL, but you can also, remember, there's that big small little patella bone right in the front of your knee, and that is a common area where injury can occur too. Now, it can happen where the patella can move out of position, or we can completely shatter it. For example, if the leg is immobilized, for example, in a football pile-up, for example, while you're trying to extend the knee, okay, those muscles can be powerful enough to pull the patella apart. Where, for example, here's your quadriceps tendon and your patella ligament, and your patella splits in half like that, okay? Or if there's a tear in your patella ligament, this snaps, okay? And the patella bone will then move upwards because now it is no longer held in place by the patella ligament. So either or will lead to dislocation of the patella bone. Or if someone kicks you, for example, in soccer, they have those metal cleats on the bottom of the shoes. Someone accidentally kicks you in the knee really strongly, it can actually shatter this patella bone. And of course, then it needs to be replaced, okay? All right. So lastly, we'll end this chapter with a common condition that happens to all joints of the body, usually in older individuals, or, we'll talk about other problems that can lead to that too, okay? This is called arthritis. Arthritis, which is talking about inflammation of the joints, okay? And this includes all rheumatic diseases. Okay? Rheumatic meaning these are pain or stiffness affecting your musculoskeletal system. And it can affect synovial joints as well. So osteoarthritis is a type of degenerative joint disease known as DJD that happens to people over 60 years of age, and it's just due to cumulative wear and tear at the joint surfaces, or it can result from genetic factors affecting collagen formation that can lead to an eroded cartilage just like that. Rheumatoid arthritis then is actually an inflammatory condition from autoimmune response. So this is when it gets more complicated, because whenever, like I was talking about with psoriasis in the integumentary system chapter, autoimmune conditions are very difficult to treat a lot of times because it's your own immune system attacking healthy tissues. And a lot of times there are multiple reasons, or there are unknown reasons that causes your immune system to do that. We don't know why sometimes, but somehow this particular type of autoimmune disease specifically attacks your joints. So it can usually happen between anywhere from 40 to 60 years of age, and it can be a whole variety of underlying condition, allergies, bacteria infection, viral infection, or even genetic factors can all, be contributing to the disease. And this is showing you what happens with rheumatoid arthritis is that inflammation that's formed by your immune system attacking your joints. Gouty arthritis is where crystals of uric acid, which is technically a metabolic waste, but somehow they start accumulating and form within the synovial fluid of joints. Okay, an accumulation of this crystal eventually interferes with normal movement, because synovial fluid is supposed to give you that gliding, smooth motion without friction. But now you have these hard crystals in there instead of fluid, so that's why it will be painful to move. And most often it happens in the metatarsophalangeal joint of that big toe, just like that. And here's that uric acid crystal that's forming within that synovial joint. Septic arthritis, as we were talking about sepsis, so it must be dealing something with bacterial infection. So this is, or other types of pathogen infection. This is a type of infectious arthritis where your inflammation of the joint is triggered by infection of bacteria, virus, or fungus. So this is usually happens due to probably an open wound or widespread bacterial infection that affects the entire body, including your synovial joints, or for if you had an open surgery and bacteria somehow went in or something was contaminated. So that can also lead to septic arthritis. Typically it happens within the knee or the hip. Okay, so let me end by showing you the Visible Body app before I go through the practice question. So here's the Visible Body app I was talking about, and I'm going to show you the different joints I was thinking to show you about. Make sure I'm still recording. I'm very nervous about that because sometimes it just cuts in the middle. Okay, so you have the spine, for example. If we go to system and go through the spine and lateral. So this is what is I was trying to show you with that fish fin thing. This is what I was talking about in terms of the ligamentum nuchae that connects your seventh cervical vertebrae to the bottom of your skull, just like that. Okay, you see how it's different from the spinous supraspinous ligament. Let me click on that. See, supraspinous ligament that goes up to the seventh cervical vertebrae, and then there's that fish fin looking thing I was talking about that exists at the back. And then you can really see all those ligaments I was talking about with the spine, with the intervertebral joint. There's that anterior longitudinal ligament. There's that intervertebral joint. And then you have the in between, that ligament flava I was talking about. Okay, so this this app really allows you to use your fingers to pinch and enlarge, smaller, and point at things. I think this app normally costs about 23 or 27, I forgot, but I didn't buy it at that price. I bought this app when it was on sale for I forgot how much, but it was really cheap around Black Friday. So that's why I bought this app, and find it really useful for 2401 when we're identifying all this stuff. Now we want to look at the knee, then we can look at region, and then we can look at the knee here. And this is here where we can look at those different areas of the knee. There's that patella kneecap, and there's that patella ligament we were talking about. And then you have your patellar retinaculum or retinicula. And in the back is where you see, we can actually cut away the nerves and the lymph vessels so you can see that joint better. Okay, let me cut away. Okay, so I cut away the popliteal ligament, and now you can see this meniscus, lateral meniscus, this medial meniscus, and then the ACL and the PCL right there. Okay, PCL goes through that hole within the knee joint, and the ACL goes through the other side towards the front. Is what holds that knee crisscross in between the condyles of the femur. Okay, and here's that lateral collateral ligament, LCL, which connects to the fibula bone, and this is that MCL, which connects to the tibia side of the bone of the knee joints. Okay, and then the thoracic cage is the thing I wanted to show you too. That movement I was saying with the ribs. So here is your ribs. When I click on it, there is a movie that shows you that movement as your rib is going back to normal. Your lungs are contracting, you're breathing out, and then you're breathing in, which then moves your rib cage outwards. Okay, so breathe out, rib cage goes in, and then breathe in, your rib cage goes outwards and upwards. Okay. All right, so that's all I wanted to show you here. It actually has a lot more features, but wherever I see applicable and needed, I will show you these in some of these animations from this app. Okay, so we'll go through and finish the chapter with practice questions, and then we'll be done. Okay, so all synovial joints are diarthrosis, like I was talking about. In a newborn infant, the large bones of the skull are joined by fibrous connective tissue. The joints are blank and will grow, interlock, and form immovable joints called blank joints. Synarthrosis, okay, and those are the sutro joints, which are the bones between bones of the skull. Which answer below is an example of an amphiarthrotic joint? Amphiarthrotic, it moves slightly. So you have syndesmosis and symphysis. And don't forget, so those are the syndesmosis. Remember, those are between the tibia and fibula that I said has to have that slight give, because that's what allows your ankles to move. And then the symphysis between pubic bones is what allows for childbirth, for example. And symphysis between vertebral bodies is what allows you to flex a little bit on your backbone. If you're looking at synchondrosis in a skeleton, you'll be looking at the joint between the first rib and the manubrium, and also epiphyseal cartilage between epiphysis and the diaphysis. Remember, synchondrosis has to do with cartilage, and there's that sternum and the ribs, and then you have those epiphyseal cartilage in the growing bone. Bursa contain which fluid? Synovial fluid, okay, because bursa is part of your synovial joint. Joints are classified structurally as what? Based on what? Okay, cartilaginous, fibrous, bony, or synovial, and this is based on the material that binds the joint. Okay, all of these other ones are the subtypes, and this is the functional classification. This is talking about structural classification, and these are the 3 structural classification. Joints are classified functionally. So it is functionally as synarthrosis, amphiarthrosis, or diarthrosis, which is based on range of movement. Remember this S for stop, no movement, amphi for slight movement, diarthrosis for free movement. Which joints are considered as pivot joints? Okay, you have, remember, pivot is for rotation. So those that are between the radius and the ulna when you're able to do supination and pronation. Okay. When you do jumping jacks, which lower limb movements are necessary? So you're doing jumping jacks, so you're widening your leg and closing in your legs. So abduction and adduction. So that's another good way to remember abduction, adduction. That's what you're doing when you're doing jumping jacks. Types of angular motion include which of the following movements? Both circumduction and abduction, adduction. Pronation and supination is not an angular motion. It is a rotational motion. A person standing on her toes is blank, while a person kneeling is blank. So standing on her toes is plantar flexing. Remember I said tiptoeing, okay? And then the person that is kneeling is actually flexing his leg. Here's the leg, okay? Kneeling. So you are decreasing the angle of your knees, okay? So flexing his leg, flexion. Which vertebral movements are involved in looking at the ceiling, bending your neck side to side, moving your chin? So first of all, looking at the ceiling, okay, you have hyperextension, bending your neck side to side, lateral flexion, and moving your chin to your chest, flexion of the neck. So that's what the correct choice is. You have a young adult patient complaining of joint pain and inflammation. Her uric acid levels are abnormal. So your diagnosis is gouty arthritis, and the causes uric acid crystals are within the synovial fluid. So that's all I have for you, and I will see you in chapter 10.